start again. I'll sum up and wrap around in nutshell with templates. The how to optimize the treatment protocols for the patients, the diagnostics, how to derive inferences, simple OPD procedures, advanced diagnostics. Of course, we mere mortals don't have access to the kind of equipment and technology which Natasha has access to at Naran Netralaya and Rohit. But we'll try and see what we can do with whatever we have. No financial disclosure. And as I said, this is not the way to be. Even this photograph, the mask is not in the right way method. It should have been like this, COVID times. So let's see, what is the future market of looking at, the commercial angle, the dry eye market, what does the future look like? What are the opportunities available for us to treat and benefit our patients and impact their lives? And there are reports there have been conferences specially held on this with Allergan, Novartis, Santen and all. And 218, they did a conference where they predicted that by 2014, the dry eye treatment market, especially let's look at our area, is going to go up by 47%. And henceforth, across the world, the average boost in dry eye cases, treatment modalities, options available, pharma, diagnostics is going to be average up by 50% in the next 3 years. The pathology in nutshell, as we all know, excessive evaporation or secretory issues. I'll be going very fast. The tear lipids, as we all know, they help to keep the tear film stable from evaporating. Mucin actually anchors it and spreads it across. And water, of course, water layer takes care of it. Now, each part is done by a different gland. I'm just kind of summarizing whatever has been done. The oily components is done by the lipid secreting meibomian glands. The risk factors, let's look at the ophthalmic risk factors. You have blepharitis, excessive contact lens wearers, Demodex, dry eye disease, which is caused by, post-LASIK, chronic uveitis, systemic factors like androgen deficiencies, menopause, aging populations, thyroids, Sjogren syndromes. Vitamin D is really coming up very in the bandwidth of everywhere for all of us. Last year, I attended a session with Rohit, and after that, I started performing this test regularly in my dry eye clinic, and I was fairly surprised to catch a lot of vitamin D associations. Psoriasis, atopy, medications, patients on antiandrogens, benign prostatic hyperplasia, BAK containing eye drops. A lot of times the eye drops themselves are culprits, especially in our post-cataract patients. Patients are using a lot of drops, and that bad lid hygiene together is a good mixture for the dry eye to actually flare up. So BAK containing preservatives, anti-glaucoma medicines are well known to cause dry eye. Antihistaminics, a lot of these patients will be going to a general physician, which I've seen. They'll go for irritation, redness, and watering of the eyes. And guess what does the general physician do? He gives them Avil. He gives them cetirizine because he thinks it's an allergy. And guess what? It's a bad mixture. The patient gets aggravated dry eye. So at least 7 to 8% of patients in my clinic, if they visited a general physician, are on anti-allergic. Can you believe that? So once I have trained my optometrist to take histories of oral medication and specifically ask for anti-allergic medication. So I'm surprised 7% of patients are on some anti-allergic medication for watery eyes and irritation, which to a general physician, probably it makes sense. But for us, it's sacrilege. So a lot of antidepressants also would aggravate the situation. The current pattern probably of dry eye would be starting with aqueous eye drops, gels, and as the disease severity keeps going up, we have punctal plugs, retreatments, surgical options, topical steroids, cyclosporins, chloroquine drops, 0.03%, meibomian gland massage and stimulation. The biggest problem is a lot of us are just treating the patient with a lubricant. And that's the toughest thing for a lubricant to take care of all the issues. The lubricant will have to take care of the viscosity, the surface coverage, inflammation, and a lot of other factors, irritants. So one single lubricant will not take care. So the second thing I've seen is a lot of these patients come to me with one antihistaminic and a lubricating dry off given by the general physician. And sometimes these lubricating drops are off the shelf available, and guess what do they have? They may have BAK in it. So that's another ignition to the big bomb blast. So all these things are happening in the market. So once you have a keen eye to catch these things, you'll realize that these things are aggravating the patient's problem. And as I mentioned, we've gained a lot of fan following in the patients from fellow neighboring clinics because they do not have dry eye clinics and dry eye specialists. And these patients are saying, Dr. Kapur, we've been going to this clinic for 4 months. My problem is still the same. And I've come here and now I'm feeling better. Now I want to get the second eye operated here. Now that adds to a lot of goodwill into the market. So let us come to the fact that let us all agree that meibomian gland dysfunction is one of the largest causes of evaporative dry eye disease. The pathophysiology, as we all know, is going to be like there's a hyperkeratinization of the whole pathway. There's increased viscosity, which causes obstruction of the meibomian gland orifice. It leads to intraglandular cystic dilatation, dropout, atrophy, low secretion, and then it causes lesser meibomian gland available. Then it starts causing an evaporative dry eye because there's a tear film instability, hyperosmolality, and you have bacterial growth and inflammation. So this is what the cascade of the whole thing would look like. This is a way you would probably want to measure or quantify your MGD. I'm going very fast because I realize most of the things have been discussed. I'm just wrapping it up. The main symptoms of the dry eye probably are stinging, burning, stringy mucus. A lot of times patient would come and say, Doctor Saab, aankh se dhaga nikalta hai. And I would wonder what's wrong. Till I finally saw the dhaga one day. And I saw it on the slit lamp. Because the lady would come and say, Doctor Saab, aankh se dhage nikalte hai. So I could never figure out that what they're referring to is mucus because, the stringy mucus. So eyelid redness, difficulty in wearing contact lenses, nighttime driving, paradoxical watering. So when you tell this patient that you have a dry eye, they refuse to believe it. They say, Doctor Saab, dry eye kaise hai? Pani jharna nikalta rehta hai. I have a tap of water flowing out of my eye. So such patients will take you not very seriously, but you need to sit. So what we have is we have a little video, a 45-second video, which tells what does the tear gland do with the blinking movement, and then another 2-minute video of the general meibomian gland structure and animation to make the patient understand. So the core mechanism, as we all know, in the end, it's the increased cytokinins and hyperosmolarity, which increases the inflammation. Different questionnaires to be employed. Most popular is the OSDI. You employ these questionnaires to quantify and to see the direction and see the progress of these patients. As Natasha has discussed it beautifully, so I will just jump this again. Now, these are a few patients. You can see, your slit lamp photographs. We take these slit lamp photographs and show it to the patients. We tell them, you see, there is a froth. So I tell them that, what would you feel if you had soap in your eye? So they say it'll burn, it'll water. So I tell them this is what is happening. You have kind of soap in your eye. So when I tell you have soap in the eye, it is watering. So the watering is in reflex to the soap in the eye. You're actually, the eye is dry, and they get it. And we show them these photographs. And once the treatment is over, they're doing better. We take comparative photographs, and we on my EMR, we save the old photographs on that folder date, and we compare the photograph and show them to them. So you have non-invasive tests, which can be done on simple slit lamp. You do dry clinical evaluation. You have tear film height analysis, debris, mucus strands, fluorescein, rose bengal, lysamine green, Schirmer's 2. These are all tests which are done in a particular sequence, as Dr. Natasha beautifully explained them. They are done in the OPD. Now, why we are doing these tests is, number one, to diagnose the patient. Number two, to quantify the degree of the disease. And number three, to map the progress or improvement of these patients. So once you keep doing these tests and noting them down and showing the results to the patient actually starts feeling better. Again, the clinical characteristics, as I said, as MGD is one of the leading causes. Blepharitis, gland dropout, seborrhea, repeated chalazions is another condition. A lot of patients will come to you with repeated chalazions. They may not be exactly manifesting the symptoms of a dry eye to start with. The change in the alteration of the Marx's line. Now, you could actually check the functionality of the gland. So what I do is I have connected my slit lamp with a television screen in my OPD. So a lot of times when I push the eyelid margin and those white serpents of toothpaste come out, I show it to the patient's relative. So they are actually amazed because they can never imagine that something like this would come out of the skin. So I tell them this is like coconut oil frozen in winters, and it is not lubricating your eyes. So now they understand the importance of giving hot fermentation, because I tell them that if you do hot fermentation, this frozen coconut oil will start moving. It's obstructing the path. It's not lubricating your eye. So we use a lot of these examples and vivid simulations in our OPD to help the patient understand. Mebography, again, Natasha has explained it beautifully. You can quantify the amount of loss of meibomian glands by the surface area. We use cirrus mapping, and also in our SBM and IDRA. The approved dry eye treatment menu would be, start with artificial tear substitutes, gels and ointments. Omega-3 is still a little bit of questionable role, using of punctal plugs, avoiding offending agents if the patient is on eye drops and BAK. Anti-allergic medications can be used. Tea tree oil. I've recently started for a few months this tea tree oil in these patients with blepharitis and Demodex. I'm very, very happy with this. Using of bandage contact lenses, moisture containing spectacle glasses. Now, I'll just jump fast now. Now, the preservatives themselves are a huge culprit. So when you're trying to optimize the treatment for these patients, you need to decide what is the kind of preservative the drop you have. Even if you're giving an adjunct dry eye treatment, but there are some other concomitant eye drops being used by the patients, you need to know what are the kind of preservatives you're using. BAK is notorious to cause dry eye and toxic. It's very toxic to the epithelium. Now, selection of the artificial teardrop. Preservative artificial teardrop could be used in a moderate to severe dry eye with high viscosity gels. Artificial teardrops with HP guar is ideally suited for evaporative dry eyes. Sodium hyaluronic acid has greater hydration, more than 50% of times the water retention. Rebapamide is a drug which we use very frequently when there's a special mucus deficiency. Now, these are the serpents I was talking about. Now, these serpents are very, very ominous of chronic MGD. Warm compresses really helps these patients, improving the eyelid hygiene. And as Dr. Rohit said, doxycycline, azithromycin, a combination of cyclosporin, chloroquine drops, and surface drops, they help these patients. Now, the reason why I'm trying to touch all these is they all would make a complete umbrella of treatment of the dry eye. Most of the times, a lot of surgeons are just putting them on methyl cellulose or polyethylene glycol and thinking that job is not happening. Now, new horizons are, hormone replacement therapy, artificial reclaimant gland, vitamin therapy, and now I'll be talking about light pulse therapy. I'll just jump to that. Now how do we start diagnosing? I'll jump the video. I'll just, in interferometry, to actually see the lipid layer, these machines are very sensitive. As Dr. Natasha said, in our machine, we can get 3D simulation of the gland, and you are able to assess the health of the meibomian gland. You're able to measure the tear meniscus using this SBM machine. We've been using this. We started using this. First, we bought one of them, and over time, we started realizing that's really helpful in helping my patients in dry eye. So I've started using it in all my centers now, and all our centers are equipped with this machine, and it's really helping. More than the fact that it adds to the revenue, it actually helps you treat your patients, get to understand what is the real problem bothering them, and then you can actually start targeting them specifically rather than just carpet bombing them with whatever you have. Tear film blinking time. Now, these are some of the reports, interesting reports. Now, what happens here in SBM is the report is very pictographic. So every patient is able to understand the report. So once you have a printout, we show it to the patient and we say, okay, now this is how fast your tear dries up. And we tell them that this is a speedometer. The more it moves toward red, the worse off you are. And the more it is in the green signal, the better you are. So I think it's a very lucid explanation which can be given to the patient. So we tell them lipid, because they all understand lipid. When I tell them aapka lipid test hona, so they understand it's fat. We tell them aapka lipid theek hai, but aapki tear meniscus height, aapke aankh mein aansu kam hai, there are less of tears. So such patients and such improvement protocols are shown. The patient is encouraged to save these in his file. Now, every time he comes after the pulse therapy or a treatment, we show them the reports and how the improvement is happening. And they are very, very happy and satisfied. Without these images, a lot of times the patient himself doesn't know he's feeling better. But if he sees the images and reports, he's far more convinced. Now, these are the blink measurements. Now, this is a patient whose one eye used to water, and we were trying to wonder what is happening. His other eye was absolutely normal. This is his other eye. The meepography was absolutely fine, but there was an issue with the blink rate. Now, this is an incomplete blink. He's blinking by 55% only. Now, that's what was causing the watering in this patient. So as I said, patient satisfaction is very important. Once the patient actually starts seeing the imagery and the improvement as he moves along. And now coming to this EI technology, I think we bought it nearly 10 to 12 months ago. We've done nearly 250 cases because from March onwards, we are closed down. So we're not doing any. So till March, I think in the period of 4 to 5 months, I've done 250 cases of treatment and followed them over time and had very, very promising results. This is based on, regulated pulse technology, whereas the other technologies available are just simple IPL. I'm going very fast. Actually, the difference is this is probably 25 to 30% more efficacious because every 2 or 3 pulses, there's a regulated pulse which gives more energy and the pulse energy keeps changing. Now, most of your patients will be coming in the dry eye segment would be 20 to 40% of your OPD. And most of them would be having some or the other kind of an MGD. So this is what the pulse therapy would work. Dr. Rohit Shetty has actually explained it beautifully. So I skipped those 2-3 slides. It stimulates the nerves to have more secretions from the lacrimal gland. And it's a very simple procedure. Anybody can do that. You just need to cover the patient's eyelid, put in a gel, and apply 5 shots along the path, the described diagram. And it's got a beautiful response. We tell the patient that do not expect a response within first 10 to 15 days, but most of them, they do agree that they do start feeling better. It could be psychosomatic. So what we've done is we've just collected 250 patients plus. Now this is a patient distribution of the patients we did, 267 patients. Now these patients were mild symptoms, were approximately 13%. This again, I took a leaf out of Rohit's suggestion once, that if I take the patient in the early stage, mild stage, he stops rubbing and inflaming the eye again and again. And they're the ones who actually don't proceed further to get bad. Now, approximately 78% of the patients after a period of 3 to 4 months were better on the OSDI score. They felt significantly better and felt a reduction in their eye drops. Now, this is the patient who started on mild symptoms. Nearly 78-90% were better at the end of 3 months. Moderate symptoms, severe patients, approximately 67 to 68% patients are feeling better and reduction of eye drops. So I guess, thank you. So I guess,
Kamal, I think I'll have to say that, what an amazing, I mean, I thought everything had been said, and I was wondering what Kamal is going to talk about, but you found so much to speak about, and also amazingly well placed there. And yes, your experiences with this technology have been fantastic. So I think you did a great job, and I don't have to mention that almost all of us did, unless Natasha, you have any question for Kamal's talk?
No, I'm thoroughly impressed. Like you said, sir, we thought there'd be hardly anything left to speak, but you just brought out such small nuances in the history taking to eventually talking of how the dry eye treatment is much better in earlier cases. So such small nuances were brought out which were clinically so relevant. So thank you for highlighting those points. I just had one question. So how long do you see after doing EI? How much time does a patient need to symptomatically feel better? Like earliest?
Okay, earliest I had my first experience with EI. I'll share with you, and that's where I'll start. It came to me for my demonstration. I have a cousin brother of mine who had a severe MGD. He's been on doxycycline, erythromycin, name a thing. And I did my first session on him just as a trial. The machine was with me for demonstration. So what actually broke my cookie was on the 4th day, I'm a Punjabi. So on the 4th day, he's elder to me, but he says, Pape, I love you. And this man was suffering so much so he was having depression because of his eye. If I would show you the photographs of his red congested eye, he couldn't go for meetings. He's a big businessman. He would wear dark glasses because people would think he's drunk. So that's where I got my first confidence that this was on the 4th day of therapy, first session. Most of the patients on the 10th to 12th day, if you actually probe them, they say yes, slightly better. But the graph starts taking on after the second therapy.
Okay.
That's where it starts actually kicking in. That's on the 20th day onwards. Second session onwards, the patient themselves with volunteers, you don't need to ask them. 60-70% of the patients, without you asking them, says, Dr. Kapur, this time I'm feeling better. Last time you just asked me, so I was forced to say yes. But this time I'm definitely feeling better. So I think I would say oddball figure of anything beyond around 20 days is the time when they start feeling better.